For a case of fever, using our mnemonic old cards will note the onset or when did your fever start. For the duration, we like to know if your fever has been constant since it started or if it's occurring more intermittently. If that's the case, we'll note the frequency. That is, how long does an episode of your fever last for and how many times per day are you feverish. Next, we'll want to note the progression. Does your fever appear to be occurring more frequently or more severely? Or if there has been no progression or no change in the fever, we'll also want to state that in our patient note to show we've asked. To help characterize and find the cause of the fever, we're going to reintroduce our stick figure to remind us to complete a head-to-toe survey, as we'll see below, to help find the cause of the fever. And for the head, we could use HINT as a mnemonic. Treatments tried, and for the severity, we'll ask about the degree of the fever. In all pediatric patients, instead of a physical exam, we're going to use our mnemonic BITTER to remind us to ask about the birth history, immunizations, developmental history, diet, education, and to reflect with the parent. Also, for all cases, we'll order a physical exam, CBC, and serum electrolytes. Starting with the head, for meningitis, our supporting points include a fever, headache, stiff neck, petechial rash, decreased oral intake, bulging fontanelles, nausea and vomiting, and since vomiting is a bodily fluid, we remember to use our mnemonic A, B, and C to write down for our patient note the amount, blood, the color, bilious or non-bilious, and daycare attendance, and we'll order an LP with CSF analysis. In otitis externa or otitis media, we'll see a fever, and in otitis externa, it will be aggravated by pulling and accompanied by an ear discharge, and we'll use our mnemonic A, B, and C. And in otitis media, it will be alleviated by pulling with a history of a recent URI, runny nose, cough, or sore throat. And in both, we'll note a daycare attendance. And we'll order an otoscopy. In a viral URI, the common cold, sinusitis, pharyngitis, or laryngitis, we'll see a fever, runny nose, and cough. And for both, we want to ask about the amount, blood, and color, sinus pressure, sore throat, and in a young pediatric patient that may not be able to communicate, we can ask the parent if there's been a decreased oral intake, a rash in the case of scarlet fever, hoarseness, and daycare attendance, and we'll order a respiratory viral panel. In a bacterial URI, we can see the same symptoms as we saw with the viral URI, and what helps us differentiate a bacterial sinusitis from a viral sinusitis includes the time course if it's been greater than 10 days or the phenomenon of double sickening, which is a worsening after an initial improvement. What helps us differentiate the bacterial pharyngitis from the viral pharyngitis include the Centaur criteria, or tonsillar exudates, tender lymphadenopathy, an absent cough, and a fever. And for epiglottitis, Haemophilus, or strep, we'll see the 3 Ds, drooling, dysphagia, or respiratory distress. And we'll order a rapid strep test and a throat culture. In a pneumonia, we'll see a fever with a runny nose and cough, and we'll use our mnemonic A, B, and C, shortness of breath, and again, in a young pediatric patient that may not be able to communicate that, we can ask the parent if there's been any change in the breathing pattern, belly breathing or nasal flaring, and daycare attendance, and we'll order a pulse oximetry, a chest x-ray, and a sputum gram stain and culture. In gastroenteritis, we'll see a fever, abdominal pain, and again, if the pediatric patient is young and may not be able to communicate that, they could be pointing to their stomach, nausea, vomiting, and diarrhea, and we'll use our mnemonic A, B, and C. And similar to an adult patient, how we asked about the bowel movements per day for the amount, in a pediatric patient, we'll ask about the diapers per day, a history of travel or restaurant exposure, and daycare attendance. And we'll order an x-ray of the abdomen, stool leukocyte OMP and culture, rotavirus assay, and Shiga toxin. In a urinary tract infection, we'll see a fever, polyuria, and we'll use our mnemonic A, B, and C, and for the amount, we'll ask about the diapers per day, dysuria, and again, in a pediatric patient that may not be able to communicate the pain, we'll ask the parent if there's been any crying while urinating, and daycare attendance, and we'll order a urinalysis and urine culture. For a viral exanthem, measles, mumps, or rubella, we'll see a fever, and the high yield being a skin rash in our review of symptoms for skin changes, and also they'll be unimmunized when we ask about the immunizations and daycare attendance. We'll order viral antibodies or titers. And finally, in bacteremia or sepsis, we'll see a high fever. Our patient will be unimmunized when we ask about the immunizations, and we'll have a history of skin cuts and daycare attendance, and we'll order blood cultures.